Ethel, it's always so nice to meet you.
Well, very, very nice to see you again, Anita.
We know
I'm
each
looking forward
other.
to seeing you in the flesh one day soon.
So now we are going to talk about water birth. That is one of your principal interest in your job. First question. When you started in the 19th to using water in Oxford in hospital, there was no evidence about the use of water, but maybe more trust in those who proposed this practice. Now there are good evidence because there are a lot of works on safety, but generally speaking, more distrust both from women and professionals. What has changed in the culture? What do you think has changed in the culture?
Well, I suppose if we go backwards for a minute, I mean, back in 1990, it was very unusual to have a water pool. There was interest. There was interest from coming from different places. One place was a national report in Britain. It was the first time a report from the women themselves, feeling that they were from the Department of Health, feeling that they were in a factory like the peas, and that birth was very mechanistic. Um, and it was also the beginning of this concept of evidence to support practice. So we had no, there was beginning of a movement, if you like, back then. And whilst everything was very traditional and very fragmented and very fixed, there was also this energy coming. So we were the first in 1990 to introduce a custom-made birth pool, permanent, plugged in, switched on, um, plumbed pool in an NHS hospital. And you're right, there was really only two areas of evidence then. One was an American midwife, Linda Church, and she had done 100 case histories, if you like, using a birth pool. And there was a midwife in England called Diane Garland, who had in Kent, Maidstone in Kent, who had like a bath at home. She had called it the Lagoon Room. And she was beginning to have it more for labor than for water birth. So we started in a culture, you could argue, that was very traditional, very hierarchical. Um, but the difference, I think, Anita, well, a fundamental difference between then and now. Then it was really a big deal to put a birth pool in, and it was a bit of drama, to put it mildly. For me, I became a little bit grey haired already with the experience. But I mean, what is different? Well, for me, there was this generation of obstetricians who had been with midwives when they were medical students. They had placements in communities with midwives. And one thing in general they understood was physiology. And they understood what midwives do. And so, and there was a generation of midwives who really knew what to do. In England, they were in the community. They lived in the community where it was more the social model was still existing, less than before because hospitals were being promoted. So there was an innate knowledge base, there was clinical skills, and there was trust between the two professions. Although very hierarchical, there was this respect. So from the perspective of putting a woman in a birth pool, it was not okay because they should give birth on the bed, blah, blah, blah. But there was that feeling that you could try it. They weren't happy with it, but you could try it. And I said, we collect data from the first woman who uses it. And the neonatologist as well, very upset indeed at first, all'inizio. And I think that's the fundamental difference between then and now. There was a curiosity, there was a respect, not happy, but prepared to give it a try. Now, the whole of society in most, I think, middle and high income countries, in my exposure, they are risk adverse cultures. And there's a whole new world of social media. There are huge differences in technology, and people are extremely risk adverse. So I say, I take care of my car, I have it serviced, I keep it in the right petrol, blah, blah, blah. I don't feel I need to open the front of the car every time I get into it. Now, every pregnant woman is micro managed, micro screened, micro analyzed. We're looking for risk all the time. And so I think now, and it's very binary, it's either the language in the UK, and I don't think it's just the UK, young student midwives, medical students, qualified midwives, qualified obstetricians. Is she high risk or is she low risk? It's completely binary, and it's completely stupid and inaccurate to categorize people in this way along a pregnancy. Everyone is an individual. So the rhetoric in the UK, the rhetoric is personalized care, better births, individualized care, but it isn't. The reality is not this, because we are so anxious, we are so risk adverse. So to me, that's the fundamental difference.
Now, we have good evidence that from study, reviews, and that so on, that in normal women, labor and birth, water birth is a good option for women. And you think that we need further study to demonstrate that there is a security, it's okay for the women, or we have enough evidence for normal women?
Okay, well, it's a very important question, this. I mean, what is normal? So you're quite right. It's like anything. I think, so let's call them healthy pregnant women.
Yes, it's better.
They have one baby, they go through a pregnancy, they're straightforward this time. And most of the actual published research on water immersion for labor, there's two things. So a birth pool is an intervention. It is a very complex intervention. It is a nuanced intervention. And there's two elements to it. Some women, they use it for the labor, and they think, oh, they don't like it, or the midwife doesn't like it, or the doctor doesn't like it, or there's a reason she gets out, concern. And then there's the population, within the water population, that stay there and give birth to their baby in the water. And I think we have a lot of evidence now, and it's high quality evidence. What I do not think we need more individual studies on the healthy pregnant women. However, there are within those studies, like my systematic review from 22, which had 36 studies, some of those studies included women of mixed risk. So, for example, high BMI, essential hypertension may be well controlled, normal for her. Previous cesarean section, this pregnancy, fine. Maybe she is a nullip, actually, because nulliparous, because the first was elective section for, let us say, breech presentation. So her body hasn't labored before, but she has a previous Caesar. Maybe it's a woman who has a pre-existing condition. Maybe she has Ehlers-Danlos, multiple sclerosis, but she can move. She can walk a little bit with help. Why can she not be in the pool? Maybe she's straightforward pregnancy. She's having twin babies, 2 babies in there. We have the technology now with telemetry. But I think we do need more research for 2 reasons. One, to translate the research that we have, the body of research on healthy pregnant women. We need to be able to translate it because we know, absolutely we know it works. Women like it. They have fewer interventions, and these are statistically significant repeatedly, repeatedly, repeatedly. The babies are okay in the main. They are perfectly okay. If you compare it with land, straightforward, it's better. Even if she gets out and she doesn't have a water birth, even if she gets out for a concern, they still are more likely to go on and have a spontaneous vaginal birth than women who never go into it. So we know, but what I mean by translate is, what are the ingredients that make it work? And midwives behave differently when they care for women in water. The same midwife when she cares for women out of water. She's more anxious. She is quicker to intervene, even if everything's okay. She needs more reassurance. Also, so we need to translate this. We know in the UK, and they also know in Australia, that birth setting makes a difference. Every single hospital in the UK has at least one birth pool on its labour ward. Every single hospital, that is 156 hospitals, who have at least one plumbed-in birth pool on their hospital labour ward. Everyone is underused. In birth settings, in the same hospital, upstairs, across there, you have an alongside midwifery unit with 3 or 4 birth pools, 1 or 2 to 4. In every one of them, they are using the pool all the time. So we know birth setting makes a difference. The midwife's behavior makes a difference. We also know from other research, the model of care makes a difference. And it's common sense, if I know you and I'm your midwife, or I'm one of 3 midwives, I might be one of 4, but you know us all. You've seen us all. You've seen me and more than them because I'm your link. Through the pregnancy, when it comes to you having your contractions in labor. We already know each other. You don't have to invent yourself. So if we're using water, I already know you want to try this or you don't want to try it. I know you, you know me. There's a trust between us. I've probably met your partner, so I know your family. It is a different relationship. So this is what I mean about translating water. Globally, the World Health Organization last November brought out a position statement. Stop the train. So many cesarean sections, so many inductions of labor, no concomitant improvement in maternal or neonatal outcomes. So we need to be able to think about physiological processes. And we need to think of the context of where we're doing the care, in or out of water. And I think for the water research, that's what we need to be able to collect the information, contextual information. And we know in UK and in Australia, I know at the moment, and parts of America, certain states where they can use water and midwives can work as midwives, that women of mixed risk are using the water. For example, induction of labor, so-called prolonged pregnancy, previous cesarean section, mild preeclampsia or some blood's okay, gestational diabetic, larger woman. So we know this is happening, so we need to collect the information about it because we know it's perfectly fine for most healthy women. And so we need to know what is happening for those women. We also, in the UK, we know that there's inequity of access. So the midwife tends to, if I say, I'd like to use the pool, the midwife reacts very positively in general. However, if I don't say it, she doesn't promote it, especially if I'm a woman of color. So if I'm a migrant, if I am Black or Asian, she doesn't initiate. She will be fine if I say it, but a lot of these women are not saying it, but they're thinking about it. So this is why I want to, and this has been flagged in a study done down in the south of England, that women, they're not using water, and it's not because they don't want to necessarily. So I hope that answers a little bit.
A little more. How you think can water prevent complications that are more frequent in medium high risk? Which is the trigger to use for hypertension, induction, pre-section, so on? You think that is not a specific reason?
Yeah, I think, well, you can have the same effect on land if you have the skills and you know each other. It's much easier, but it's not impossible if you don't know. But if you're a midwife who trusts and understands physiology and trusts in it, the whole thing is it's around optimizing physiological processes. In water, you can move around with more ease. You have to work harder if she's stuck on a horrible hospital bed. What is the environment like? These things influence all the evidence about water. If I am stuck on a hard bed looking at a clock, having people do things to me, Even if I'm perfectly healthy, there are places still doing routine cardiotochographs when a woman appears in a hospital. It's ridiculous. There is no evidence to support this. This shows you one thing: accelerate towards cesarean section. Epidural. So if you are in, you can have it on land, as I keep saying, but in the water, it's an automatic. You can move more easily. You show your endorphins. You progress well. These things, if you have a risk factor, if you have some hypertension, in the early studies, when there was nothing, as you said, on women laboring in water, decades ago, they did some work on aerospace when they are training astronauts, and they immersed them in water. And they found it reduced blood pressure, it calmed vasopressin, and so on. And an American midwife, Tracy Benfield, for her PhD, she immersed women, pregnant women, in birth pools, and she took every 20 minutes, she took blood tests, and she noticed what we noticed when they first go in the pool. Even if they're having strong contractions, they go off a little bit. When they change environment, it's normal. When shifts change, if a woman is in labor in a labor ward or in a birth center, and there is a change of midwife, change of staff, they slow down the contractions until the mother readapts. And then she found they come back 30, 40 minutes, they are back. But they know scientifically there is less risk of cortisol, the catecholamines. And we know that they do not help placental perfusion to a baby. So if, for example, we have a small baby in there, and she's a little bit preeclamptic, well, I would think put her in the pool, because we have the telemetry now. We can keep an eye on the baby. We can take her blood pressure. The odds are she's going to be a lot calmer in there, rather than giving her maybe an epidural. I'm not anti-epidural, but I'm saying we can optimize physiological processes more easily using water. It seems to be very beneficial in the neurohormonal context.
Can you explain in really brief which is your intention with this witching study?
Okay. So alongside trying to translate what we know to work out the factors that help or hinder people in water or out of water, and for the sake of equity and for the sake of global concern about too little, too late, too much, too soon interventions. Women of mixed risk, we need to be able to actually be open, be honest, and collect this information, because it is happening, but we're not getting what happens, what typically happens to women. So rather than doing it by stealth, we want to do, I want us to do it openly. So the first step is to do the feasibility study, which is WCIC. So women of mixed risk with complexity to some extent use it in and out of a birth pool, maybe just for labor, maybe for labor and birth, what typically happens to them. So the idea of the feasibility study, and it is an international collaboration, and it's absolutely wonderful to have Monza involved and to have a place representing Italy involved in this, because I don't know of any published research on this. So the point is, I got no money to do this because it's too new and it's very easy to do to collect some anonymized, routinely collected data in places where they are offering birth pool to mothers of mixed risk anyway. It is happening. So it's to capture this. And the purpose of it is to inform a funded study. And I'm also doing PPI, so that's involving service users, women who might be pregnant now with a risk factor, might not be pregnant now, might have had a baby, would have liked to have used it, but couldn't because she was too big, whatever. So I'm doing some work with PPI, so the combination of the data.
PPI, it means, what means PPI?
Personal and professional involvement. So it's in order to do research, to apply for funded research, you need for something like this in midwifery, because medics, they have no problem getting big grants, whereas midwives in general around the world have a big problem getting serious grants for midwifery, especially something like a birth pool, even in 2025. So to have the WCIC study, to have the feasibility data, to have the personal from the ground, the women themselves, because now in the UK, NIHR, so that's government funded research grants, it has to be coming also from the people who use the intervention of some kind, or it's of interest to them in some way, or they want to know more about it. So really that's why I'm doing it. So what I see happening is we get some initial data from different places, different care contexts, different care models, different types of pool, different clinical guidelines, because that's another thing. Everywhere seems to have a different guideline, despite very consistent, simple information publication. Everything is individual. So collecting context, care model in operation, except across different places, and the women's perspectives. So I see it happening, some focus group, maybe 2 focus groups in 2 different places around Oxfordshire, because we have a melting pot. I want to get different ethnicities as well. So I'm speaking to an imam, because one of my students is introducing me to an imam, so that I get the permission to actually speak to some of these people about this kind of thing. Because a lot of women, they think they can't have clothes on, have anything on in the pool. And large women sometimes very self-conscious. And for some cultures, it's not okay to be naked in front of the husband and so on in labor. So I say, why are we automatically not making it clear that she can wear what she wants? She can be in the pool with something on her. It really doesn't matter what she's. After a while, she feels comfortable, she feels warm, she can take it off if she wants, but she doesn't have to be naked in the pool. Just saying that to some women, they have said to me, Thank you for telling me that. Thank you, because this is my worry. So it's to collect the information, do something with the information, and apply for funding. And I have a steering group that will inform the design of the study.
Last question. You did a mixed method review on barriers and facilitators on birthing pool. Can you briefly say which were the results?
Yeah. Well, so I mentioned already, it's a very good question, this. It's very important because in the UK right now, they are underutilized in the obstetric unit. So basically, there needs to be for it to work. This review indicates there has to be alignment between organizational factors, multi-professional cohesion, and skills, the clinical skills. So where it seems to work is basically where people respect each other, trust each other, have an inquiring mind, not casual, but just they support physiology. So where you have this kind of cohesion and good working relationships, good leadership, it happens. It happens more. And on Wicked, it's very interesting for me at the moment because I have 13 places, different trusts operating on it now in England. Well, 2 in Wales and the rest in England. And they are different worlds. And it's very interesting. I'm getting information about the care model, the clinical guidelines, how many births they have a year, how they all offer birth pool to women with risk factors. That is the eligibility for Wicked. So, but the cohesion, the use of the pool and how and when they use it is very individual. But where I see the most activity is in the most remote part of the country, Powys in Wales, where the midwives don't have a hospital nearby. They are using it much more. So it is influencing. I think intra and inter country, even though there's international evidence there, it does vary a lot. The usage.